newspapers, etc., etc. But if the weather is cold, it's been quite interesting how numbers sort of are not so great. What I will do is I will do a brief. This is not going to be death by PowerPoint. It will be a brief presentation. You've all been given printouts as well. Just to set the scene, I'm actually more interested in engaging in a conversation in these meetings, just so that everyone can understand actually what I'm suggesting here and what I'm proposing, and therefore sort of, it would be nice if there were more here, but broaden the understanding of where healthcare is going and whether the Thames Valley wants to be part of the future or whether it wants to sort of hang on to what it's got, which I would suggest is not as good as it should be for historic legacy reasons. I don't think there's anyone else. I might as well fire away, I think. Anyway, well, look, good evening, everybody. My name is Phillip Lee. I'm a Member of Parliament for Bracknell constituency. My constituency is not wholly served by Heatherwood and Wexham Trust. Heatherwood and Wexham notionally, historically, has covered just the town of Bracknell. The border of it is sort of gone down into Crowthorne. In fact, if you worked as a GP in Crowthorne, traditionally, you could go three ways. You could go to the Royal Berks, you could go to Phillip Park, or to Heatherwood and Wexham. The other parts of my constituency are served by Frimley. Sandhurst is Frimley Park, and Finchampstead, which is served by the Royal Berkshire. I make that point because actually the constituency, in terms of its healthcare, is indicative of the problem and the challenges we have in designing acute healthcare in the 21st century. It is pretty daft that we have a situation where 77,000 voters and their families are served by 3 acute trusts. It's not sustainable, and I said that 3 years ago. A couple of weeks ago, we hear that Heatherwood and Wexham are now in talks to merge with Frimley Park, which is consistent with what I've been saying for 3 years, and I don't have a copyright on that. If you spoke to local clinicians, they would have all pretty much said the same thing. They'd all have their different views about where mergers should take place, but most clinicians will tell you that staffing and delivering care on the number of acute sites that we have in this country is just not sustainable. So with that in mind, and with the fact that I am also a practicing doctor, I've done probably the majority of my general practice work here in Slough, up at the Farnham Road Surgery and round the corner at Sippenham Surgery. But I've also worked throughout the region as a GP, and I worked as a junior doctor at Wexham, a junior doctor at Stoke Mandeville, and I also did out-of-hours GP work at Wickham Hospital, Heatherwood Hospital, and I have referred into Royal Berkshire Hospital on a number of occasions. So I've got sort of rather unique experience in that regard, but also I suppose I am unique in that I'm also a Member of Parliament in that region. So that sort of confluence of experience, knowledge, and dare I say a small modicum of wisdom, what came to pass was that I realised that I had a responsibility, indeed a duty, to put forward this plan, not a perfect one. I'm sure anybody with any knowledge of the area can pick holes in the plan, but it was prepared by 2 of us in our spare time. It's not part of my remit as a Member of Parliament to do things like this. But we put it together as best we could. And the idea was to say, look, before we go down the path of make, do and mend, which is basically the mantra of healthcare in Britain generally, why don't we step back and think, right, well, how would we want this to be delivered in the 21st century when chronic care is massively growing, we have an ageing population, and where acute care is becoming increasingly specialised and increasingly difficult to staff. So with that in mind, I put this together. The original plan is available on my website, but this is just a brief, and apologies for the small type, but this is just a brief overview. And I broke it down into sort of sections. Essentially, the key, if there's one thing you take home tonight, is that if you want the best clinical outcomes, you want a hub and spoke model of care. You want acute sites served by a series of chronic community hospital sites feeding into that acute site. All of the evidence points towards that. They've recently consolidated stroke services, for example, in London. It's saving hundreds of lives, and the projection is if they did the same thing across the country, we would save between 2,500 and 3,000 lives a year just on stroke services consolidation. A single building, if you go to any hospital site pretty much in the country, it's an exercise in, well, a variety of architectures are on display at every single hospital site. It's, you know, the 1960s wing, the 1970s wing, a couple of porta cabins that were always temporary but they're never removed. What you do by building it is that you, first of all, you create this state-of-the-art facility, but also it becomes sustainable. It's energy, cost, the electricity cost, the energy costs of going forward are significant, and we've all just seen recently that Ofgem report on the cost of energy for the country in the next 10, 20, 30 years. Consolidation also will save the country money in terms of the heating of and the electric going into hospitals. So that's actually quite a significant point in terms of the long-term sustainability of all of the hospital sites that we have. And then staffing, EU directive on junior doctors' hours is a real challenge, particularly in surgery. By putting it all on one site and having cross-covering and everything else within surgery and indeed medical specialities, it builds better relationships, handovers are better, continuity of care is better, but also training is better. The future consultants get more experience because more and more patients are coming through, because they're serving more patients by having fewer hospitals. So, and then just over here, just a few key figures just to mull over whilst I'm going through. That's a guesstimate of about approximately how much money we're talking about. It's a guesstimate because clearly the cost of land and also the cost of building in the southeast is possibly different to the rest of the country. If you look at hospitals online, different hospitals have been built in the last 10, 15 years. The costs are quite varied. Some of it's to do with the way in which it's been funded. I'm not a huge enthusiast for PFI contracts of the past, so that. I think we've been rather shafted as a nation with our PFI contracts of the past, and I think if we were going to go down that path, we would have to be very careful with our contracts. But essentially, I'm suggesting, and this is again another guesstimate based upon prime location, I'm saying that there is actually quite significant money to be released from selling land. For example, as part of this plan, I've suggested selling off Heatherwood Hospital, and don't underestimate the politics of that for me in Bracknell. The reason being is because Heatherwood is a very valuable site. It overlooks the Royal Ascot Racecourse. It's a short walk down the hill to the railway station to go into London. But my point is, it's not in a very good location at all, and the hospital itself is in a pretty shocking state of repair. And I would rather see a consolidation. I need to make a comment about this slide being out of date. I would rather see a consolidation at the Brants Bridge, not Healthspace, Brants Bridge. That's wrong, that bit. It's changed since I first did. I'd rather see a consolidation of chronic care service, for example, in Bracknell, because that's where a lot of people live, and a consolidation in Upton, because a lot of people live in Slough. At the moment, we have things like Heatherwood, which is opposite a racecourse. I mean, it's not actually near a population-dense area. And you have the perverse situation, actually, that 80% of patients seen at Heatherwood are actually being bused and taxied over from Slough. Okay, they're not local people. They're sustaining Heatherwood by busing people over from here. So anyway, this map, I basically pitched off this piece of land from England, okay? By definition, that means I might have got it wrong. But the problem is there isn't a national plan in place for where acute hubs should be. There should be a national plan. I know it's a bit odd for a Conservative to be talking like a communist, but there should be a central plan here, because you've got to look around the country and you've got to look at all the motorways, you've got to look where all the population density is, the demographics, and say, right, we need one there, one there, one there, one there. You cannot have a market in acute and emergency care. It's just not, doesn't make any sense. You're having a heart attack, you have a road accident, it's not like you go, I'll go to Asda. and then I'll get a Sainsbury's. It's not like that. You just go to the casualty department and you get treated. So, but unfortunately, there isn't a national plan. Neither the Conservatives or Labour governments have considered that this is needed, which I don't understand. And so I've had to just go local, shall we say. And I chose this area because this was the area that I knew. I was born here, I live here, and I'm an MP here, and I've worked here and here and here and everywhere, 50 GP surgeries. So this was an area I knew, so I felt confident about this area and choosing it. But I recognise that it can have knock-on effects on other hospitals and other health economies. Of course it can, that's the definition of the obvious, of course it can. But my belief was that there was going to be a consolidation of services along the M4, so that you can choose where along the M4, but that's where it's going to be. Because to get to a big hospital serving over 500,000 people, you've got to be on a motorway, by definition, because more and more people have got to get there, and also you've got a hard shoulder, so if there's traffic problems, the ambulances can go zooming down the hard shoulder and everything else. It's a sort of statement of the obvious for me that it has to be, and I chose Junction 8-9 mainly because it was in the middle of this population, but also because it was at the bottom of a bypass coming up from Wickham, and it was the M4 going down here. And there should be a road from here to here, and that's my next project. I sort of think that I've never understood why you can't turn left at Junction 8-9 on the M4 as you come out of London. It's a bizarre situation. But I'm told, I've been reliably told that there are plans from the past for a road linking the two, which I'm about to get my hands on. But that's why I chose that site. Now, I'll go to the next. This is just a brief package of idea. That's the forecast on population. So we're going to go to top over 1 million by the end of this decade. But this one, apologies for the detail, this is really significant. These are the sort of council areas, approximately, and this is the ageing profile. I mean, essentially, that is slightly more pronounced in this part of the world compared to other parts of the country. We have an ageing society, and with ageing societies, you get increased chronic illness. This is just a thing about financing. I won't go on about this too much because it's very detailed, it's in the thing. Essentially, Eva and I, my researcher, were trying to be estate agents and property developers. But the point we're trying to make here is that we just used a 2-bedroom flat, X square metres, how many can you get on a site? And it was remarkable, the figures you got. But I'll just leave that with you, and these average prices of prime location and everything else. And of course, there's population density, flat density issues and strategic plans and everything else that I didn't even bother going into. It was just the central point was, I thought, and pretty confident, there are hundreds of millions of pounds to be released, if we want to. So essentially, the new region hospital, about 500. I said this figure because I recognise that if we're going to develop communities, facilities that are top-notch, at Upton, at Wickham, Bracknell, there's going to be additional expenditure. And I never wanted to put forward a plan that was underestimating cost. I actually think, what's happened here? Can we go and find some? Let's come back on again now. The lights just come back on. Do you know how this works?
There's on power and we're
I
going to
think
get
you lost it now.
yeah, we're going to get some.
Now coming back on again. Yeah. I didn't want to be accused of underestimating the cost of all this. I actually think I overestimated the cost in many ways. There are some hospitals where they've done the whole of this for 250 million, 300 million. But I didn't want to be sort of coming out with figures that people would then say, oh, you haven't got a clue. It can be done at less money. But even if it is, they're coming. Even if it's making funny noises. Do Do I need to reboot this?
No, I think it's automatic, so...
Anyway, so in summary, the sort of the services that you will get from this new hospital, services that actually you don't currently have, include a primary trauma centre. Now, at the moment in Thames Valley, the nearest primary trauma centre is either in central London or it's at Oxford. I've always found that surprising because we've got the M4 motorway, we have the Great Western Railway, we have Crossrail, we have the approach to Heathrow Airport, we have a whole variety of different things. We have a hugely population-dense area, as I've just said, 1 million people, and we don't have a primary trauma centre. We also don't have a 24-hour cardiac unit, and as I understand it, we don't have a 24-hour stroke unit, but there may have been some changes on that at Royal Berks since this was made. And in terms of what I mean by enhanced surgical services is that there are some surgical specialities that are not as well represented around here as they could be. The community services, this is where there's going to be growth in terms of the top three. I'm not suggesting that people are going to have to be bussing in to go to outpatient appointments at Junction 8-9. There's no reason why the outpatient appointments can't be offered actually in community hospitals, GP surgeries, closer to people's homes. All I'm suggesting is if you're properly sick, if you really are unwell, if you've had a road accident, if you've got a heart attack, a stroke, if you've had a brain hemorrhage, whatever it is, the sort of serious stuff that we all sort of worry about, what's going to happen if that happens to us, you want to be going to a hospital where they can sort you out. But if you're having an outpatient appointment with your diabetologist, or if you're having an outpatient appointment with your rheumatologist, or with your psychiatrist, or whatever it is, you actually can do that in a community hospital, in a clinic, in a GP surgery. Why not? Why does it have to be in an acute hospital? There's no reason for that. There are some outpatient appointments which I suspect would be on the site, probably make the more narrow surgical specialities where you've probably got somebody who needs to stay on site to provide the cover on site as well as also do an outpatient clinic every fortnight or whatever. But they're the small numbers. There's no reason why you can't actually move the outpatients away from acute hospital sites. The minor injury units is, I'm not a huge fan of minor injury units, I must put that on record, but I recognise that the general public quite like the concept of minor injury units, so there's a bit of a political judgment there. The reason I'm not a big fan is the minor injury unit at Maidenhead, when I worked at St Mark's, it was never used, and when I was at Heatherwood as a GP, people would come through and say, oh, we're not sure about this one, doctor, and I was the only medic there. There are no doctors in minor injury units. And if they did come to see me, by definition, they'd delay the proper care. So, why have them? But anyway, just in conclusion, just a few points. It's not a significant sum of money. We're spending over £700 billion this year as a nation, the government is, and so it's less than 0.1% of central government. And if you think that £20 billion net transfer from the southeast of England every year to the rest of the country, I don't think it's a big, and that's just business rates. It's not income tax, it's not VAT, that's just business rates, net transfer to the rest of the country. It's about time we had a proper hospital, I think. This is about serving 650,000 plus people, plus all those people who work in the area. Thousands of people travel into the area who could also get sick. And it's for the next 40 years. It's a long-term punt. And I think, you know, if you look at those sort of figures, £750 million is modest. It's a modest investment. It's not a lot of money at all, really. If you think about it, 40 years, serving 750,000 people in an area of Europe that is one of the most economically vibrant, is peanuts, actually, in that context. Thank you. So, I'm sure I've not answered everything. I'm sure I haven't gone into enough detail and all those sort of things. But I'd rather now just have questions from you all about it. The last thing I'd say is that this isn't easy politics for me. Suffice to say, you know, the easy thing for me would be to stand outside Heatherwood Hospital with my banner saying "Defend Heatherwood." which incidentally I have been told to do by some people I know. And I personally, I can't do that in all honesty, because I know that we can do things better. I know we can have a better service. I know we can have a better hospital, and we can have better clinical outcomes in the Thames Valley if we actually cross the Rubicon and go, right, okay, let's go for this. I recognise that change is difficult in politics. Change is difficult for everybody, really. And the concept of closing Wexham Park is everyone will go, where am I going to go? And the concept of Wickham becoming smaller and closing and building on Heatherwood, and all these things are difficult things to wrestle with. I understand. But this is the way that healthcare is going. We're going to have fewer acute sites in Britain in the next 20 years, and we're going to have more chronic care being delivered in the community. That's what's happening. As a region, as a community, we need to say, right, okay, that's how it is. What's going to be the best outcome for us? And my suggestion is that that's a big hospital on the M4 and a series of community clinics offering the care closer to people that I've described. The location at Junction 8-9 was just one I chose. I didn't have any piece of land in mind, but I just chose it because I thought it had good infrastructure potential in terms of roads that it had and the potential for possibly a new road down to Bracknell. I thought that that was a good location, but I'm not wedded to it. I recognise that particularly if the Royal Berks came into play on this plan, which isn't part of my plan, but just say that it did, that there may be a movement towards Reading with the location. There may not. The concept that I'm talking about here is we're going to have to consolidate our acute services. That's my strong belief. The choice is